Okay, Sergio,
Yes, can you hear
are
me?
you ready?
Yes, you want to try sharing?
Yes, please.
Give me a second.
Abdullah, أنت معانا?
Here you go. Can you see it?
Yeah, great.
ايوه
Perfect.
حضرتك يا دكتور.
Great. احنا هنبتدي كمان دقيقتين بالظبط. I think we still have 2 minutes. دكتور عماد ازيك؟
أهلا دكتور أيمن، مبارك إن شاء الله.
يا رب. Chantal, nice to see you.
Maybe she cannot hear us.
Nice to see you too. Hello, everyone.
Ciao Chantal, lovely to see you.
Jojo.
Ciao Matt.
Hi, everyone.
Ciao Tanya.
Hi, how are you, Sergio?
What is good? Where are you?
Alhamdulillah. I'm good, I'm good.
Okay. And I was with Omar just 48 hours ago, so I don't know if Omar is here with us, but we had some good time in Dubai.
Yes.
We feel really cold these days in
Yeah,
Cairo.
indeed. I came back with a cold from Dubai. I think that's the first time in the history. It was flown. It
Take care.
It was raining so much. It was terrible.
was crazy. My friends couldn't believe it was for real in Dubai.
Yeah. They activate the code red because of the floodings in Abu Dhabi and Abu Dubai, both things. So Monday was chaotic, really. Anyhow, we survived it. That's
We're
fine.
sorry for Professor Makoto. Mo from Japan was the first time was going to Dubai, and he was all ready to enjoy the sun and the good weather. And
Oh, that's painful.
for him, yes. Ciao, Lowell.
Hello there. Nice to see you guys.
Nice to see you.
I'm in my scrubs.
How you
Yeah,
doing,
me
Lord?
too. Me too. No shame about it. I'm on call.
Keep the good job, guys.
I've got a lot of fake news.
Yeah.
Oh, really?
One is I'm not working.
Oh.
This is fake. Hello, Samer.
Hi, man. How are you guys?
Fine.
Dr. Summer, you're looking elegant with a tie. What is this? I'm not with my scrubs. I feel
It's
embarrassed right
Valentine.
now.
Come on, it's Valentine.
Oh my God. That's very unfair.
Is
I
that the
should have
official
wear something
OR
better.
outfit?
I'm on call. I'm on call.
How
So
was you,
just in
Valentine?
case. You look very smart. Wallahi, a lot.
So,
Hello,
what
guys.
I'm going to start it. Who's going to start and what's the plan, Ayman?
Yes, we'll start. First, Sergio will talk about varicose vein in athletes, followed by Kabnik, followed by Samer in pregnancy, and Kanata in children, and Tanya in topical and medical treatment, with comments from Yasmina, Willy, Chantal, Zaza, and Omar. Okay, guys.
Quick question. Are you playing the videos?
Yes,
Okay.
if you need.
Yeah, just play mine. It's fine.
Okay.
I'm
Yeah,
gonna
mine
have to
too.
jump. I'm gonna have to jump at 30 minutes, so or maybe a little longer, but unfortunately I have a business meeting with the group I'm working with now. And I have to jump on it. I'm sorry. But I'll do the best I can say to stay on.
Good luck, dear. Okay, now, guys, we are going to start. 3, 2, 1. Okay. Good afternoon. It's nice to see you all from all the world. It's our meeting today. On behalf of the Egyptian Venous Forum board, I'd like to welcome dear professors Sergio Gensini, Lowell Kapnick, Samer Kosayer, Victor Kanata, Tanya Gozman, Yasmina Shisha, Willy Shee, Chantal Aguero, Zaza Lazarvici, and dear friend Omar Farouk and dear Professor Ahmed Din Hussein. Today we are going to discuss what's fake news about varicose veins. As we always taking the advantage to talk about the real things, and we have many questions about varicose veins in different populations. Let's start by Sergio Janseni, and he's talk about Sergio Janseni is a professor of vascular surgery for University, and he's the president of International Union of Phlebology and president of Viewing Foundation. Sergio will talk about varicose vein in athletes. What's true and what's false? The mic is yours, Sergio.
Thank you so much, Professor Fakir and the Egyptian Venous Forum. It's a pleasure to brainstorm together about who a good sport is for varicose veins. And indeed, I picked up this picture with dilated varicosities because it's very common to find dilations in our athletes and also in amateurs who are practicing sport. So it becomes quite a question that goes back to the origin of the same UAP, because Glauco Bassi was one of the founders of the UAP. Back in the days, was wondering how we could really define a varicose vein. Now, the answer could be a tortuous dilated vein, or it could be, as he was used to say, the natural response to venous hypertension. So a sort of dilation might become a natural response to a physiological state like the one of the volume overload that you have during sport practice. And that's why I like the statement that if size really matter, well, the elephant should be the king of the jungle, not the lion. This is to point out the concepts of the volume overload that can be, let's say, paraphysiological compared to a real impairment of the hemodynamics, because indeed also athletes can actually present a pathological dilation as per this picture that very probably is associated with a leaking point from the gluteal region. So papers like this one by Merlin are very interesting and unfortunately very rare. So this is a very good topic, the one of varicosities in sport, and if we really have to treat them, because on one side they might be just physiological, but on the other side it's very interesting how these athletes, in particular the high level of practice, are actually presenting, as you see from the literature, an increased risk of developing something pathological for real. If we think about the Lancet paper that actually gave origins to the Viewing Foundation, because we were inspired by this Lancet call to action, we just go back to 2015 when also Serena Williams in sport was an example of this, because the Lancet at that time said it's very important that whoever is involved with venous awareness deals with education in thrombotic risk, because there are several athletes that indeed demonstrated that agonism might have the word agony inside, meaning the risk of thrombosis when you are like stretching too much human body, because also of different sports condition as per these very important examples. If we go back to the pathophysiology of the phenomenon, we see that the whole triad of Virchow can come into the game also in terms of sport practice. Because if we talk about stasis, we see that with bradycardia and hypotension that are kind of typical of the high-level athletes that are there. Together with the positioning, we know about endofibrosis, for example, not just in the arteries, but also in the veins of the cyclists who are bending in a position that is not very good for our iliac system. At the same time, in the literature, you find the mention of the high hydrostatic column in basketball player. I think we need a little bit more data before really confirming that fact. While in reality, it's quite evident that athletes are actually flying potentially quite a lot when they are in championships, and this means also a related risk. As it is for the trauma sports that are then leading, of course, to another factor that can be associated with endothelium damage and at the same time with the stasis of the triad of Virchow. In the literature, you can find that there is endothelial damage also because of the repetition of the efforts associated with specific sports like bodybuilding in this case. And of course, it is interesting how, in particular in this case, female athletes might be exposed to the risk of the hormonal therapy associated with the need of controlling the cycle, so oral contraceptive, and on the other side, for gender equality, I would say also the anabolic use that, of course, we strongly discourage as per the erythropoietin cases that are indeed leading to an hypercoagulability state that has been reported in the literature as a risk, eventually not really wanted by the subject in case of the sport we are talking about is done at high altitude, for which you have, of course, a natural release of erythropoietin, or because you have an exertion that is associated with a thrombocytosis phenomenon, again, as per these nice papers that, if you look carefully, are coming from quite an older literature. So we have been knowing this for quite a long time, but we usually don't talk that much about this. There are like some very interesting papers also like this one about the aggregation of the blood that is changing some sports, like again in cyclists. It is very important for these athletes to follow a webinar like the one of today, because 6.7 months are lost for a DVT case in athletes, which means a huge amount of time if you think about the sport time span that they have available in their career. 6 months is a long time for a professional athlete. So to dive a little bit more in the topic of what is true or not in terms of sport practice and varicosities and how we can counteract it, I think another question we might have is if these colleagues and friends are wearing or not compression in this picture while we went running all together. And that's interesting to me, how maybe it's still like a bigger question mark that will not have an answer today, because if you look at papers like these ones, there is no real benefit in having compression for these guys, while there are other papers that are saying that there is. So it really depends on the study population you are analyzing and the objective outcome measures you are considering. And again, there are contradictory data in terms of running and the use of compression stocking. So indirectly, we could say running and venous circulation. Well, there is quite a lot of fake if you go around the web, because you see how much has been spent for, let's say, compressive garments that are not really certified compressive garments. So does it really make sense as experts to suggest them? Well, when I see commercial, and again, this is a real commercial that is talking about improving circulation without really explaining to us what they mean by improving the circulation and all the other things we see over there, according to the literature, I think we can agree that we can just talk about the delay onset of muscle soreness that has been clearly demonstrated. But all the rest is a run toward the evidence that we are still missing. So it's very important that we discuss again about this, because there are great potentials. With proper certified compression, they demonstrated with a very serious study, for example, that if you use a 30 versus 18 versus a sham, you have a decrease in the fatigue at the triceps surae in electromyography. So this is an objective measure. But we could also discuss about graduated versus progressive compression, so more pressure at the calf level, because both of these kind of compression are going to reduce the volume of the lower limb. But in reality, if we are talking about chronic venous disease patients, there is a different effect with better benefit from graduated rather than progressive. While if we are talking just about the ejection fraction, we know that progressive compression is actually better. This is one of the studies we have done on the topic in healthy subjects, looking at what happens when you're using compression in a standardized way, meaning that people were not just walking randomly, they were walking on a treadmill with a calculated speed based on their heart rate performances. And we measured also the perceived exertion. And we demonstrated that not only you control the volume as we could expect, but also you control the perceived exertion. So again, there is a potential great benefit in the use of compression for patients also without eventually varicose veins, so just normal subjects. But more literature is needed, because if we really think about that, even when we are suggesting to our patients to go walking, if the patients are smart enough to ask us if they can go with their dog so that they can walk intermittently because the dog stops and go, we don't have that much data. Actually, none before we did a study on the topic. And that's why we really looked at the topic of continuous versus intermittent walking, for which we did a study with the sham 18 and 23 on golfers. So this is another sport. And it's very interesting, as it is a fake news to say that golf is good because you go walking. Because if you go walking, it's more the time that you wait for the other flight in front of you to shoot the ball. So actually, you're spending more time standing up still rather than walking, and we clearly demonstrated that. So if you use proper compression at 23, you actually control the volume, and you also control the perceived exertion. So a little bit of a fake is in that sense that golf is good per se. It really depends on how you're practicing. So again, in conclusion, I think that there is not one size fits all, of course, because you have some preliminary data that are suggesting that in basketball, for example, sport, you have the possibility of having a perceived exertion reduction thanks to the use of proper compression. You actually have the same in volleyball with a better jumping performance, in particular for the females rather than the males. There is a potential benefit even in the upper arms, as you can see from the flow data in rugby wheelchairs player. But again, these are preliminary data that still are forcing us to speak out against articles like this one of the Mirror, that, as you can see, is stating that soccer player cannot use stockings so much that it's painful for them and they have to make these holes on the stockings, when in reality, clearly, these are not certified products. It is indirectly very interesting, the experience we had with the Giro d'Italia, with the professionals of the cycling, because for them it's even considered doping, the use of stockings, because of the great improvement you might have in performance. So in this sense, very probably the venous system is a little bit overloaded, I would say, during the normal practice, for which proper compression is helpful, even so much to be considered, as I was saying, doping. In conclusion, I think it's very well placed, this webinar by Professor Fakhri and the Egyptian Venous Forum, because we really have to stop commercials like this one that are talking about aiding performances or improving blood circulation, as I said before, without really specifying what they mean, as we should stop this kind of practice that has a lot of use, particularly, for example, in my country and in many other countries, but without proper evidence, for which we try to use the compression of water in a very physics and evidence-based way, placing specific protocols that have now been recognized in the last Cochrane also as the only randomized comparative trial on the topic, for which I really look forward for collaborating more and more with the ones interested in this area. I take this chance to remind you that you can report eventually encountered fake news in the dedicated web page we created with the Viewing Foundation in 2022, following the large event we did in Dubai, and the related publication that you can now find has 100 pages for the expert in international angiology and in 12 pages booklet for all the patients and public. This is also the reason why we are putting during the Vein Week, for which you are all invited to take part, a day entirely dedicated to sport. And as it will happen, of course, in Indonesia, sport will be present because it's the best drug we can use, as long as we use it properly. Like, drugs can be beneficial or harmful based on how you use them. Same thing for the sport practice. And just 1 second to say that UIP, as we used to say, starts with you. So it's an honor for me to invite everybody to get engaged with the UIP in case you are interested. Thank you so much.
Thank you, Sergio. It's a very nice lecture. I think we all enjoyed the talk very much. I have a few questions from the audience, but listen first to comment from dear friend Yasmin Ashish from Morocco. Yasmin, ready?
Yes. Good day, everyone. I'm really honored to be with you. Thank you, Professor Fakhri, for the invitation, and thank you, Professor Gianissini, for your brilliant presentation. People do not typically think that athletes and sports professionals would encounter issues related to leg venous circulation. There is evidence suggesting that repetitive strain from certain activities such as heavy weight lifting and intense running and cycling could potentially cause venous modifications. But the very interesting VariSport study that you mentioned conclude that we still need to determine whether athletic veins are truly pathological varicose veins or simply an adaptation to high physical activity volumes. And regarding thromboembolic disease, according to a Dutch recent review, VTE events can be linked to sports activities with varying sites of incidence depending on the type of sport. specific factors accompanying VTE may have distinct application locally, and symptoms typically of VTE may be obscured by sport-specific symptoms. So awareness is crucial, and early diagnosis through D-dimer testing or imaging can be beneficial, but please don't forget that VTE is a multifactorial phenomenon and need an etiological assessment. So my question is, do you think that all athletes should wear a compression, or should we rather adopt a personalized approach based on each individual's risk factors for varicose veins and thromboembolic disease? Thank you.
Thank you so much for your comprehensive insight, Jasmine. Of course, I think not only that you should customize, but also you should think if using or not. Let me give you an example. There are situations like running, particularly if it is intense, in which I have the feeling the normal compression is actually not really able to counteract the explosion of the calf pump. But of course, I'm talking just about everyday compression, let's say so, because we should also talk about the different stiffness you might have. It's not just about the dose of millimeter mercury, but also the stiffness, so the working pressure rather than the resting pressure you're going to have. So there are really antipodes, I would say, in compression, because if you have the experience, for example, of going running, as I said, maybe you don't have that great benefit while you're running, but in terms of recovery after running, that's a great benefit. If you go skiing, to the contrary, for some preliminary data we are collecting, you have a great benefit in using compression during skiing. Same thing when you're doing small movements, like it happened in another data collection we did on motorbike riders. And I came to the conclusion that if you use normal compression, so not the one with high working pressures, you have a benefit in all the sports in which you have mild movements that might benefit from an enhancement of the edema control. If you are having explosion sports, I would say that either you go with high working pressure material, or maybe you don't have that great benefit. So absolutely, you need to customize, and that's the beauty of compression. One size does not fit all.
Thanks, Sergio. I have a question from the attendees. One of our attendees is asking, he noticed many athletes developed varicose veins after quitting their practice of sports. Do you think varicose veins develop in athletes during their practice of sports, or after they stop practicing sports?
So if I understand the question correctly, somebody noticed that varicose veins are increasing after they finish practicing sport. Is it correct, Simon? Is this the question?
Yes, after he stopped playing.
Well, first thing, that just to make a little bit of a joke, I would say that we don't get younger as time goes by. So once you stop, of course, you are aging a little bit. Not only you're aging normally, but you age after having stretched your body. And you know this as an Olympic champ. You really stretched your body so much with a volume overload most of the time, for which you could even hypothesize that the elastin component of your elastic lamina of your vessels have been stretched far more than a normal person. It really depends also on the sport, because if you are talking about, for example, golf will be totally different from even fencing, I would say, where you have like explosion activity of the calf pump. So I would say makes sense. I have no data, and I don't think it will be very easy to demonstrate this, because you have so many variable factors that could come into the play, like the job you eventually started doing after, the kind of familiarity you have, like the kind of eventual previous trauma you had on those veins, but it makes sense that you stress your body quite a bit more. And the interesting thing would be correlating the dilation of these varicosities with the real hemodynamic impairment. Very probably these athletes will have big varicosities with no significant hemodynamics changes.
Great. Tanya, you have a question?
Yeah, I was having a question. Thank you very much for the presentation. It's been very enlightening. I have enjoyed. I'm sure you have seen a lot of heavy lifter weighters. Actually, I have a couple of cases of heavy lift weighters, female and male, that were complaining of varicose veins. Actually, they were having a duplex ultrasound showing reflux. They were complaining mainly more because of symptoms because, you know, these people is very focused on their physical looking. Cosmetically, they don't like varicosities. They want to show off the muscle. And I'm talking about culturists, people who is professionally heavy lifting a lot. So I did a surgery for them. It was a very good result. But of course, the recurrency question was there. And at some point, I thought that they developed varicose veins because of the repeated Valsalva maneuver when they were lifting weight. So I recommended them using elastic stockings regularly during the heavy weight lifting. I mean, what is your experience or what was your recommendation with this type of patients, Sergio?
This is a brilliant question, because indeed you really have to balance the needs of the patient. So of course you must be extremely clear with them that it's not even a recurrence. It's, as I said at the beginning of my talk, I would say the natural response of the human body to the venous hypertension solicitation. So if they claim to do this for aesthetic purposes, you have to claim with them that they have to stop practicing what they are doing, I would say, because one thing you could try is being extremely aggressive and ablate all you can find up there. But again, the risk of a recurrence will be extremely high. At the same time, but this is pure phlebosophy, I would say, I would go for surgery rather than other ablative methods that might be less performing in a situation of stress like this. And I'm saying this based on a paper we published where there was a iliofemoral incompetence, and indeed we demonstrated that surgery was performing a little bit better. So again, I don't think also in this case there is a final answer. These are patients who must be extremely well educated about why they're having this, and stockings might help, but I'm not even so sure that elastic stockings are able to prevent the dilation, because we know that the stockings are not actually compressing those vessels, they're just pushing them in the subcutaneous tissue. So for those cases, I would suggest to look at particular stocking with high stiffness, so to at least try to control this explosion, because normal elastic material, I don't think will be really able to prevent the evolution of the condition. One thing you could try, but we don't have data, is aquatic compression, because you have 80 millimeter mercury. So after the exercise they've done, to immediately, and very probably they will have a pool nearby, do some cardio activity in the pool. But this is, again, poor phlebosophy. So I wouldn't like to foster fake news in a webinar against fake news. So let's stay on the evidence-based ones.
Thank you, Sergio. I think we are going to make more the discussion after a little bit. And now I think it's time to go to the other side of
Professor
the
Ahmaddin
tunnel.
Hussein have a question.
Yes, but we'll keep it for the end,
Okay.
because we have Lowell Kapnick and he wants to leave. So we will play his video and ask him to be ready for questions. Lowell, are you with us? We will play the video and keep you for questions. Please play the video for.
I am Professor Ayman. I just wanted to thank you for the privilege and the Egyptian Venous Forum and the support by the WIN. I have to jump to a meeting at 11:30 at 6 minutes. You can have somebody else present now, and I can rejoin if that works for you. Otherwise, play the video and I'll come back.
Okay. You can join us after half an hour?
Yes.
Great. Okay, let's move to Dr. Samer.
Thank you.
Bye-bye.
All right, guys.
Samer Kusair is going to talk about fake news of varicose veins in pregnancy. Ready, Samer?
Yeah, just let me find my, okay, this one. Let me share my screen. Here we go. You can see my screen, Ayman?
Yes.
Okay, first, good evening, everyone, and thank you, Ayman, for the invitation. It was great to be part of the Egyptian Venous Forum. I'm going to talk about varicose vein in pregnancy. Why varicose vein happen during pregnancy? The incidence usually about 10 to 20% of the pregnant woman. The cause usually because the blood volume increase during pregnancy. We know that during pregnancy, the plasma increase about 40 to 50%, and the red blood cell mass increase about 20 to 30%. And this can cause varicose vein to engorge with the blood. The second thing, because the compression of the IVC by the baby weight. And the third reason is the hormonal changes, because increased progesterone level can compromise the vein valve and relaxing vein wall. So what are the risk factors for varicose vein during pregnancy? Family history of varicose vein could be a major problems, being overweight or obese, carrying more than one fetus, and standing for a long period. So how we can prevent varicose vein during pregnancy? First, we advise the woman to avoid prolonged standing and sitting, sleep on the left side because this will take the pressure of the fetus from the IVC. We ask him also to keep their legs elevated as much as possible, maintain healthy diet, exercise to improve their blood circulation, and don't wear a high heel if they can. And sometimes we advise them to wear compression stocking. But the question, does the compression stocking help or not? This is a nice paper. They look at the compression stocking prophylactic for emergent varicose vein in pregnancy. It's a prospective randomized controlled study. And they found really that compression stocking do not prevent the emerging of gestational varicose vein, but they are significantly decrease the incidence of long saphenous vein reflux at the saphenofemoral junction and improves the leg symptoms. So what are the 5 most varicose vein myths during pregnancy? The first one, the varicose vein don't typically show up until later in pregnancy. And this is false, really. This is a fake, because varicose vein can happen at any stage of the pregnancy. At the most common location, we can see them in the inner thigh and the calf muscle, pelvic area, and vulva, and the rectal area. They present as a hemorrhoid. The second myth is that if you already have a varicose vein or spider vein, does the pregnancy make them worse? Of course, yes. And the reason, because there's a lot of factors which increase the varicose vein during pregnancy, which we already mentioned before, like increase the blood volume, hormone changes, and the physical pressure of the fetus on the IVC. The third one, if your mom had a varicose vein, you are more likely to have them. This is also true, because genetic play a significant role in weakening valve wall and faulty valves. And if your close family member has a history of varicose vein, you might be a higher risk for developing them. And while genetic can increase your risk, but they don't guarantee development of varicose vein. Number 4, varicose vein are more likely to happen with multiple pregnancy, which is of course true. And the last one, if you might also find another vein during pregnancy in different location. And this is true because you get spider vein, you can get chronic venous insufficiency, you can get a DVT, hemorrhoid, or you can even see a prominent breast vein. So the next question, can I treat varicose vein during pregnancy? Usually it's advised to wait at least 6 months after giving pregnancy or birth to explore the varicose vein treatment. But you can, in the meantime, to speed up the healing process of your varicose vein, which happened during pregnancy, by keep moving, change your diet, compression garment, and don't smoke, and limit your alcohol intake. So what are the treatment options? Like any varicose vein, you can do sclerotherapy, you can do laser, ambulatory phlebectomy, radiofrequency, venous seal, foam, or ligation and vein stripping. So what the nice guideline, they said, don't carry out any intervention treatment for varicose vein during pregnancy unless in exceptional circumstances. And consider compression hosiery for symptom relief of leg swelling associated with the varicose vein during pregnancy. But there's 2 still research recommendations which we don't know an answer yet for these 2 main questions. First, how long after giving the birth should a woman wait before having interventional treatment of varicose vein? We said about 6 months, but we don't have really strong data to support that. The second question, should women have their varicose vein treated between pregnancy or wait until they do not plan to have any more children? Also, these are controversial questions. This is a very nice paper. They look at the risk factor of the first venous thromboembolism around pregnancy. It's a population-based cohort study from United Kingdom. They found the incidence of VTE during pregnancy is 1 out of 1,600, and it considered the 7 leading cause of death of maternal death. The risk factor for antepartum VTE, it's varicose vein, multiple birth, inflammatory bowel disease, UTI, diabetes, BMI more than 30, and maternal age more than 35. And they found that postpartum VTE risk about 2 to 5 times than of antepartum, and C-section and birth complication increase the risk of VTE. What about superficial vein thrombosis? Usually it's increasing, when you have SVT during pregnancy, it's being considered as a marker really for systemic risk for more serious VTE event than just an SVT. And it's potentially more difficult diagnosis because it's very common complaint of limb swelling and limb pain, a shock of breast during pregnancy. So sometimes can go under notice. And any patient with SVT in pregnancy really should be treated as high risk for VTE. And this is very important. So how we treat SVT during pregnancy? If it's uncomplicated, if it's less than 5 centimeters in length, there's no deep venous involvement by ultrasound, low risk patient, then symptomatic care with reassessment in 7 to 10 days is advisable. But if patient has a complicated one, like she has an ultrasound, show the DVT, then you have to give a full anticoagulation. If we find a thrombus and SVT more than 5 centimeters or within 5 centimeters from the SFG, then they're going to give anticoagulant. Dose and type of anticoagulant for SVT is undetermined, but most guides suggest him to give intermittent dose of heparin, like enoxaparin 40 milligram sub-Q QD for low risk patient. But if patient high full risk or she has a DVT confirmed by DVT, then you have to give a full anticoagulation. The treatment duration is, again, it's controversial, but most people give to 45 days or until the symptoms resolve is common. So conclusion, SVT is generally a worse actor than has been traditionally thought. More DVT at time of presentation and more progression to DVT or PE immediately after diagnosis. So we have to take SVT really seriously during pregnancy. Pregnancy is highest condition for VTE with a high association death rate. Any pregnancy-related VTE is treated aggressively, and in consultation with obstetrician, try to treat SVT with intermittent heparin-based anticoagulant if patient has uncomplicated SVT, but full anticoagulation in complicated or high-risk women. Thank you very much for your attention.
Thank you, Samer.
Any question?
Sure. But before questions, we will fly all the way from Saudi Arabia to Latin America and welcome Chantal Guerrero. Ready, Chantal, for your comment?
Yes, Ayman, I think it's very interesting, and this topic is quite important, especially being a woman. And I want to see the pregnant woman in 3 different times and see in their life. I think the past is important because we have to know, as Dr. Samer mentioned, the family history, if they have some fertilization treatment, hemorrhoids, other veins. If she's obese, of course, it's very important in the past. And some fake news that I always see in the past of a pregnant woman, if she wait a long time before she start treatment, if she has to wait until she finish all the pregnant that she's programmed to have, all the babies that she's planning to have until treatment. That's something that I can always see like a very common fake news. And of course, in the present, seeing a pregnant woman in the present, we know that we have to ask for prevention if she can have already a treatment during pregnancy. And so this is something that we can also see a lot of fake news around, if she can she can start a treatment during pregnancy or not. I think it's something that we know already. And of course, thrombosis prevention and exercise, oral medication, stalking, everything that we count on in this moment. And of course, when we talk about future in the pregnant woman, we know that she have to know exactly what is going on after a pregnancy if she developed varicose vein. It's very important, the diagnosis is very important, when to start the treatment, as you mentioned, Dr. Samer, when is better to start, and especially some fake news that I also can see around this topic is that if you have to do already your treatment just after pregnancy, or you have to wait after you finish. In my country, it's very common. It's very interesting to hear different nationalities and different culture point of view. But at the end, I think the most important thing to be aware and try to work together in a synergism with the OBGYN, because they are the main physicians during these pregnancies, and they sometimes don't know about fake news. They don't explain very well. They don't send this patient to our field. So sometimes they don't really know exactly what to do. So I think probably the conclusion that I think is most important is to work together, try to find a way in our societies, develop this during campaigns as Vein Week, for example. We work together here in my country with the OBGYN, and this is very important to try to find a way to go to the same point, and of course try to be better for our patients. Thank you.
Thank you. Thank you, Chantal. I have a question from the audience. One of the audience asking, he has a lady, 34 years, pregnant, and had a saphenofemoral junction incompetence, and she's pregnant, and she's in pain. He's asking, shall this lady got treatment now after pregnancy, or he has to wait for the next pregnancy, see what will happen? What do you think, Samer?
I think, of course, during pregnancy, we do not recommend that. So she has to wait until she finishes her pregnancy. As you said, we recommend to wait at least for 6 months. The main question, should we wait until she finishes all her pregnancy? I mean, we don't have a strong data, but usually if I ask the patient, if she is not planning for pregnancy for next 2 years, I'll treat her between pregnancy. If she thinks she get pregnant less than 2 years, I prefer until she's done with all her pregnancy first.
His question,
his
question is suggesting pregnancy increase the incidence of saphenofemoral incompetence.
Yes, this is correct. This is what the study showed, is increase that, yeah. But could be a temporary, because, I mean, that's why to be assessed after the pregnancy, because after pregnancy, after she lose all the overweight and the volume she gained during pregnancy, the valve, they may go back competent again. So she need to be reviewed after she delivered her baby before you make your final decision.
Thanks, Samer. That's when we're talking about pregnancy, and it's time to talk about children. Professor Victor Kanata is going to talk about venous disorders in children. What's fake?
Can you play my video? Yes, play the video. We have the already recorded. Great.
Okay. We'll play the video. Abdullah, play the video, please.
Okay, dear friends, this is Dr. Victor Kanata. I've been called by Ayman regarding about to give a talk in vascular venous disorders in infants and children. And I will talk about hemangiomas and vascular malformation, but this is the only thing that we have in young people as well as kids. I don't have conflict of interest. I will just start for two small classifications that we have from vascular malformation and hemangioma. The term hemangioma refers to the common tumor of infancy that has a proliferative endothelium and exhibits rapid postnatal growth and slow regression during childhood. This tumor never appears in an adolescent or an adult. And vascular malformation is the second that we have. The malformations are comprised of abnormal formed channels that are lined by stable endothelium, present at birth and never regress and usually expand. We usually divide the vascular anomalies in two unique groups. The first one are only hemangiomas, and the second one are vascular malformation. They can be slow flow and fast flow. Slow flow, we will have venous, capillary, and lymphatic. And in fast flow, we will get arteriovenous fistula, arteriovenous malformation, and arterial aneurysma and ectasia. This is something that we have to see, and usually is a big trouble for us when we saw those in the office. The hemangioma is the most common tumor in infancy and appears in neonatalhood, usually within the first 2 weeks, and has defined natural history. As you can see, this beautiful kid with a large hemangioma in the forehead is a big trouble for the family, big trouble for everybody who saw the kid over there, but you have to know that this will evolve by himself, it will disappear without big trouble, and the only thing that will happen is just a big trouble for the mother who's having the kid with the big stain on the forehead. What are the clinical features? The natural history of hemangioma is characterized by 3 phases. Proliferating phase, the first one is start new, showing up and then keep growing, and with big trouble for the parents and all the family. The second one is the involuting phase, and the third one is the evolutive phase, when it already disappeared, you don't see that stuff anymore. We usually, what are the diagnostic tool and all the things that we do just to figure out what are the trouble? Hemangiomas are with other tumors. We usually use the ultrasonography. We use computerized CT scan, MRI, and arteriography. With these 4 tools, we will be able just to see what is the trouble of the patient, as well as all the problem that we can see. We will see the veins, we will see the arteries, we will check the surrounding structure, and we will be able just to make the final diagnosis of what's going on with these patients. When we talk about vascular malformation, we talk about they usually grow with kids, and they not with the rapid proliferative growth exhibited by hemangioma, and they usually are just a little bit difficult. The greatest distinction between hemangioma and malformation is the former is posteriorly involute, and the later not. Usually grow, and will just keep going with the time. Hemangiomas, unlike vascular malformation, rarely cause some bone distortion, but we have our trouble with clippertenoid. There is usually a full time of vein disease that I will talk later on in a few seconds regarding about one patient I have with that kind of trouble. The clinical presentation for venous malformation are usually localized or extensive, minor or distorted, singular or multiple, and are located in the head, limbs, trunk, all over. You can see over there a guy with a big venous malformation in the face. He usually are sporadic, blue color, soft, compressible, on palpation, slow refill, you don't see thrill, and increases size with dependency on pathognomony for venous malformation. You see, this kind of usually presentation is the way that we saw in the office. So many patients coming just to ask what will be the way that we can fix those patient and what we can do for them. Usually, we do a lot of stuff for them. We just check after the ultrasonography, the CT scan and MRI to see what's going on. And then we usually do foam sclerosing agent with polydocanol. We usually fix the problem very often without big trouble. Now, I would like to show you a case presentation of a patient that I have in my office here in Paraguay with a clippertenoid problem. This was a 27-year-old female with port wine stain, varicose vein, hypertrophy of the limbs, extra growth on one side of the limb. Then you can see in the arrows over here, you see the port wine stains as well as the enlarged veins that you have at the side and the lateral and external margin of the leg. This is a female with a big trouble that I didn't know what I had to do for her, because as you are more than aware, everybody concerned about the big stains and what is going on with the future of this patient. We take a MRI to see what's happened, and we saw the 2 or 3 enlarged veins at the sides, as well as the Giacomini veins. The lateral vein was really huge, and we didn't have trouble seeing it. And I will show you a video regarding about how is the vein and what we saw already. If you saw the vein is coming from the lateral margin, and there is another vein at the side of the patient. If you see, it's a Giacomini vein who was draining between the saphenous vein, the lesser and the bigger saphenous vein. The problem was what will be the way that we can go down with this bulging vein that the patient has, and the concern of the family was, can we do something for her? Can we do something to help her? I told them that the stains will remain over there, but if we do something, we have to fix the refluxing areas that the patient has, trying to improve the way that the malformation is already at the side of the patient, as well as the situation for the family and the patient. She was feeling a little bit of pain, not too much, but she feel a lot of problem regarding about the bulging vein that she has at the lateral side of the leg. That's why I decided to do a laser ablation. Now we have porcupine. There is some kind of treatment that usually we do, trying to fix all the veins at the same time. But this patient was really showing so many veins as you see over there. And I just decided to do a laser ablation because I think it would be the best for her. I choose to do an endovenous laser ablation with 1470 nanometer laser under local anesthesia, porcupine technique with 1 rig radial fiber. The result was really very good. The patient were very happy, and I will show you the video of the treatment. As you can see, I know that with the cure was impossible, but I told them that we will be able just to fix a little bit the patient. I introduced 1, 2, 3 large sheets, one for the lateral margin vein, the one for in the posterior aspect went for the Giacomini veins, and then I give some anesthesia. You can see how it's easily going from one side to the other. Was not too difficult trying to just go to the refluxing area of the patient, and the result was really very good. We solved most of the bulging veins. The involution of the tumor was really very good, and the patient tolerated the treatment very well. And this is so far so good, my experience that I have in vascular malformation in kids and infants. And I think we have to work a little bit more trying to just improve the way that we saw this patient, trying to help them a little bit. Thanks for having me here, and I wish you the best. I may get just a little bit of time. I'm waiting for your question. Thank you very much. And I will just to remind you that VLU has already growing a lot. We have the largest team in WhatsApp group already that work with so many physicians around the world, and we are working together trying to improve the knowledge in the venous field. Thank you very much for everybody else. Thanks, Ayman. I will take my spot trying to ask for your questions.
Thank you, Victor. Very nice demonstration, and really we enjoyed your talk about some venous disorders in children. Going to Georgia and taking comment from dear friend Zaza Lazarvici. Zaza, the mic is yours.
Yeah, thank you very much, the Ayman, for inviting me on this very interesting webinar because all the topics are very hot because we have this like these patients in everyday practice. And thank you, Victor, for this very nice presentation. I checked the literature about the varicose veins in primary varicose veins in the childhood period, and there's I can tell us to everybody that I think it's a very important problem, and we don't pay attention really for this, because only one real study in which was analyzed the big number of patients of this age is a Bochum vein study in 1990s was presented in more than 500 patients. And what was the very interesting, they found 3% of truncal varicosities in patients from 10 to 12 years group. Of course, it's very dangerous and important in this age. And also, I think screening is necessary because many, as Victor presented, in many cases of the presence of varicose veins in childhood period is the top of the iceberg, because we then found another pathology. But also there is many cases, case reports about the findings in this youngest population, but no consensus about how to treat these patients and when to treat this patient, using only conservative methods before they become in puberty period, or treat according to in the age, don't look on the age of patient. And my question to Victor is, what is your opinion? If the patients have the primary varicose truncal vein, what to do? What options you use for the treatment of these patients? Intervention or conservative? If intervention, when? In which age? Thank you.
Thank you, Zaza. Can you answer the question, Victor?
Yes, thank you, Sasa. There was a great comment and great question regarding about what we're supposed to do. But you have to remember, when you have a kid or a young adult in your office, usually there are the parents and all the family behind. And there is something that usually has to figure it out. If the patient has or not reflux, if they have some reflux in areas, you have to stop it. No matter that the patient is young, adult, or you have already know that the patient has some trouble and you can fix it. It's a little bit difficult just to figure it out when you're supposed to doing it. But my point of view is, as soon as we get it, I will fix the trouble of the patient, because the patient, all the problem will involve, the patient will not have troubles, and in the future, the leg will become the same that it was before. The second question is, and I want to open up that for the people who are doing and working in all over, trying to see what will be the best in hemangioma and in triple treatment, because those are really difficult cases. The family are involved, the adults, the young adults, or the kid is usually suffering of that trouble, and all the family is behind. There is something that we have to do and something that we have to see to help them. And the idea is, since we have so many kind of new interventional methods like laser, MOCA, we can fix it in the way that we want it, trying to improve the problem of the patient, increase the walking distance, increase let them have a better appearance of the leg, and then keep going with compression. I think this is my point of view.
Thank you very much. And Ayman, I came to continue that I'm happy, and my honor is to present it here also as a Chantal Augustine, because now as a two Chantals are during the webinar presented, and I'm happy because it's the name of my greatest and friend and so beautiful lady. Thank you.
Because fake news, Sasa.
Yes, yeah.
Fake Chantal.
On next webinar, you will Zaza.
Yeah. Thank you, Zaza, and thank you, Victor. But we have still a question from Samer.
Yeah, thank you, Dr. Kanata. It was a great lectures. My question, we see a couple of the kids, they come to us with a large varicose vein, and we do MRV, and we found absence of the IVC with both common iliac vein. So how we approach these patients? I mean, it just has large collateral. Suprarenal IVC is patent, but from renal down to both common iliac arteries, no IVC, just huge collateral. And they are suffering large varicose vein. Some of them even come with an ulcer and chronic venous hypertension. So what do you think the best way to approach this kind of patients?
You can put a stent with a piece of graft and trying to fix that refluxing areas that are coming from the iliac vein. This is something that the people who usually approach the iliac vein, they can close all the holes that refluxing are coming from the iliac veins. Or also, you can do as Tesari, you can start doing with foam, fix each area with foam, 2-3 cc of foam, 3% polydocanol will fix the trouble without big problem. Just keep going and using it under ultrasound guidance, and you will have very good results trying to fix everything. My point of view is so easy. As soon as I saw a leak, I will fix it.
No, but my question, even with the abscess IVC, you still treat the varicose vein, or they are like,
you have to start from the largest area and the highest area of reflux. If you have the reflux from the iliac veins, fix the iliac vein first, and they go down.
Okay, thank you.
Thank you, Victor. But still, we have a question from the attendees. One of our attendees is asking, he has a child, 4 years, with buccal hemangioma or AV malformation, treated with sclerotherapy without improvement after many sessions. Biopsy revealed angiosarcoma and hemangiosarcoma, and is asking, what about the risk of developing angiosarcoma in hemangiomas?
Is the transformation of that kind of we talk about tumor regarding about those is just very difficult, but sometimes it can happen. But my point of view is like this: if you saw something, you have to fix it. If you have an hemangioma in the face, I will try to go in larger amount of the sclerosing agent that you are using, use more foam, and trying to see if maybe if you have some areas that it can improve with alcohol or maybe with another agent that can help you, it will just do much better and trying to improve the way that the patient has with the hemangioma.
Thank you, Victor. Now we'll go to Tanya. Tanya would like to play the video. Okay, please play the video for Tanya.
Yes, thank you.
Thank you very much for the kind invitation to participate in this webinar. I will continue with the topic of fake news, but this time regarding to the topical treatment of the varicose veins. I will not extend much in what are the varicose veins, but they are part of a manifestation of the chronic venous deficiency, and they can range from minor cosmetic concerns to significant discomfort impacting the quality of life. And they affect a very significant portion of the adult population with an estimated pool prevalence of 19%. And right now, according to the last published guidelines, there are no topical creams for the treatment of the varicose veins. Are some of the common myths the patients believe. So there is a few of them, starting from like some idea the varicose veins are just a cosmetic issue, or later think that there is a cream that can erase the varicose vein overnight, or a cream that works better than surgery, or a cream that may make the varicose veins invisible, or that prevent varicose veins forever. Maybe there is some type of cream or patch that contains a secret ingredient. Or the last one, maybe we can make our legs look youthful again thanks to a miracle cream. But the fact is, none of these myths is true. Actually, the varicose vein is not just a cosmetic issue. Varicose veins can lead to pain, swelling, itchiness, heaviness, edema, and impact the quality of life. The fact is that there is no cream that can erase the varicose veins or work better than surgery, remove the varicose veins for surgery, or prevent that. Unfortunately, there is no magical ingredient that can revert the age of our legs. Unfortunately, misinformation can lead to suboptimal treatment decisions, so we should not underestimate the impact of the fake news on varicose veins treatment, as it can misguide the treatment decisions, and individuals may opt for the ineffective and unproven treatments based on false information, or even delay the effective intervention and potentially exacerbating their symptoms. Also, time and money are often wasted on products and treatment that offer no real benefit, diverting patients from seeking evidence-based medical advice. This information also can lead to unnecessary worry about the severity of the condition or the effectiveness of the treatments, impacting the mental well-being and increasing anxiety and stress. Not only that, fake news can undermine the patient-physician relationship, leading to skepticism towards the professional medical advice and evidence-based treatments. And finally, the widespread belief in ineffective treatments can influence public health policy and risk allocation, potentially leading to broader health implications beyond individual cases. That's why in our daily practice, we need practical tools and strategies to discern credible information from misinformation, not only for us, but also for our patients. This is crucial in empowering them to make informed decisions about the effective management of varicose veins that often requires a comprehensive approach. We should always remember ourselves and our patients to consult credible sources. Really, we need to make clear that whatever information it is found in the net should be always verified with healthcare professionals, especially vascular surgeons, if we are relating this to varicose veins. As healthcare professionals, it is our duty to keep up to date and check for the last evidence that it is available. Be aware of quick fixes or miracle cures. And also, it's very important to understand the source's motive and identify whether the source of the information has a commercial interest, as information pushing for the sale of a product may not always be reliable. This is a real-life example of what patients can find in the net. So basically I did what the patients do. I went to Google and I typed a search of varicose veins treatment with cream, and I got redirected to different websites, the most prominent of them Amazon, and I found diverse type of creams with a lot of variety, even veins patch, with very nice descriptions. Even I found a horrendous design of elastic stockings for varicose veins, not including the ankle and the foot. All of them were promising the type of myths that we have been commenting before. But what really worried me is the fact that many of these reviews were about 4 or 5 stars, and these comments are coming from patients. Like, for example, with this product here, which has more than 1,500 reviews and 4 or 5 stars. And indeed, this is a placebo effect. There is no science behind this type of creams. That's why identifying misinformation and understanding its characteristics is really important. But there are a few keys to spot fake news in general, not only for fake news and the varicose veins. So really we should be aware of the sensational headlines, especially the news that lack of an author credibility. This news with unsupported claims and information that doesn't provide evidence from clinical studies, research, or expert testimonials, outdated information, one-sided stories. We have to take in account that legitimate health news will often present various perspectives, including potential drawbacks and side effects. And of course, all the news with promotional content, that it is aiming at selling a product or service rather than providing unbiased information. I will finish my lecture with a few take-home messages. So in this era of misinformation, it's very important to provide to our patients very clear messages. The varicose veins is a very common condition, and we are going to face this situation many times. And the patient will come, hopefully, to ask us about different type of treatments that they see in the net. So we need to explain to them that the evidence-based treatments are the key. The critical evaluation of the information, it is essential. That we are invaluable when it comes to a comprehensive approach and to provide the best treatment, not Google search of Amazon. To be able to combat all this, we really need to stay informed with reliable resources and up to date. Thank you very much for your attention.
Thank you, Tanya. I think there is a little bit problem in the video, but we all enjoyed your audible presentation.
Yeah, it's a pity.
We are sorry for that. And I think dear Professor Omar Farouk has a little question and a comment for you, Tanya.
Thank you very much, Tanya, for your great presentation. I really wish we would have it with your slides, and hopefully we can have it soon over the internet. My question to you, after such a great presentation, why do you think the reviews and feedback by patient on those miracle promising product are so high?
It's something that we're going to encounter many times. Today I was doing my clinic morning and afternoon, and one of the patients came asking about these miracle creams. I don't think they are doing anything wrong to the patients or creating any bad effects, but I think that the fact they are applying the local massage is just helping her in general, because it is making a draining effect. If you also add that maybe these products of these creams, they have collagen, vitamin K, vitamin C that they are advertising, maybe they are feeling some kind of benefit on the skin. So really, I cannot say this type of creams or products are gonna make something wrong or they will create inconveniences to the patients. But if you look to the literature, if you look to the last published guidelines, none of them is recommending any cream or patches for the patients, any of them. So I really, if they wish to buy them, it's okay. But as a doctor, as a physician, I don't have any type of evidence to recommend them.
Actually, I have a very quick comment. Your lecture is great. I was just reading paper yesterday about the advert in Facebook. They done search for varicose vein, and they collected around 10,000 brochure in Facebook with varicose vein. If they compare it to fact-checking program, 90% were wrong. They done the same for Twitter, 70% were wrong. So for every physician, I think we should have a fact-checking program. And the one I use quite a lot every week is the healthnewsreviews.org. This is a dedicated fact-checking machine. You can put the sentence that you want to check it with evidence-based. Unfortunately, it is not totally available to all customers, but I think our patient, when they come to our clinic varicose vein, they are loaded with wrong information from the Facebook, from social media, from Amazon, and we should, number one, re-educate them quickly, because once patient with varicose vein have this miracle expectation, then whatever you do, he will not be happy. And many doctors, when you ask them, what is your best 5 resources of fact checking? Actually, most doctors will tell you, I don't know. So he doesn't know where to go to check. Our patient doesn't go to Stanford University and check the publication, doesn't go to medical journal, but this is the only material they have. So they think they will come to the clinic, within 10 minutes, the varicose veins will be gone forever. And this is very common occurrence. Loyal Kapnik is laughing because probably most of his patients will have this expectation. So I think as a summary of the meeting, we should direct to doctors what is the fact-checking program for vascular disease. This is the one I recommend, but there's other 4 sites. Surely artificial intelligence will rule. And sometimes I re-educate the patient and tell them, go and get this information from that place and then come back to me, because this is a reliable place. So re-education started to become quite pronounced, especially in our daily practice. And thank you very much, Ayman Fakhri, for a great topic to be discussed.
Thank you, Omar. This is a very nice comment. And thank you, Tanya, because your topic is great and very potentially dangerous, and we all meet this in our practice. Now it's time to ask Lawal to give his talk about varicose veins in elderly. We'll play the video, Lawal. Okay.
All good, thank you.
Okay, please play the video.
I would like to thank Professor Ayman Fakhri for the privilege in presenting superficial endovenous disease therapies in the elderly. I have no conflicts with this talk. Here are my take-home messages. Varicose vein procedures in the elderly are safe. The elderly benefit from varicose vein procedures with improvements of their venous clinical severity score and patient-reported outcomes. The elderly have a low rate of leg and systemic complications. What supports these messages? Registry data, observational data, including single-center and multi-center reports. So let's start. As we all know, varicose veins are a common problem with profound effects on patient quality of life. There are a variety of varicose vein procedures that we can perform that have the ability to improve vein disease and patient morbidity. The Vascular Quality Initiative Varicose Vein Registry commenced in 2015
to capture varicose vein procedures. In 2016, we described the initial results of the registry and concluded that varicose vein registry is useful in monitoring changes after varicose vein treatment, and contemporary varicose vein surgery had substantial improvements in the venous clinical severity score and patient-reported outcomes. Shortly after we proceeded to investigate clinical outcomes in the Medicare population and demonstrated that patients greater than 65 benefited from varicose vein procedures. Although these two studies addressed important gaps in the literature, what became apparent was that the group of patients greater than 80, or the octogenarian group, had not yet been explored. In 2018, Dr. Sutko published the clinical outcomes after varicose vein procedures in octogenarians within the Vascular Quality Initiative Varicose Vein Registry. Their objective was to investigate the procedures selected and the clinical outcomes in octogenarians, including SEEP class, venous clinical severity score, patient-reported outcomes, and overall complication rates. Ultimately asking the question, what specific procedures are octogenarians undergoing, and what are the clinical results and risks of complications? All varicose vein procedures from January 2015 to February 2017 were examined. This registry module includes all procedures performed C2 or greater. The clinical outcomes examined were the C component of the SEEP class, the venous clinical severity score, which includes 10 different components, and the patient-reported outcomes, which includes 7 subjective components, and finally, overall complication rates, both systemic and leg specific. After exclusions, 12,262 procedures remained. The procedures were stratified by age into 3 age groups: patients less than 65, patients between ages 65 to 79, and the octogenarian group. The 65 to 79 age group had a higher percentage of white patients, patients with a history of previous varicose vein treatment, history of DVT, and anticoagulation therapy when compared to patients less than 65. The octogenarian group had similar characteristics when compared to the 65 to 79 group, except for having a lower average BMI and the highest percentage of patients on anticoagulation. This study showed that for patients less than 65 and for patients from 65 to 79, C3 was the most common presentation. Whereas for the octogenarian group, the most common presentation for pre-procedure SEEP was 4A. The most commonly performed procedure in both groups was truncal treatment alone, followed by truncal and cluster together, concluding that providers are not performing combination therapy as often in octogenarians. In both less than 65-year-old group and the octogenarian group, with relation to VCSS improvement, post-procedure each were statistically significant with lower overall scores. With regard to patients' reported outcomes from pre to post-procedure in the less than 65-year-old group and the octogenarian group, each had improved outcomes and were statistically significant. Finally, the rate of any leg complication was about 7%, and for systemic complications, with the overall mean being about 0.5% for all age groups. Leaving the VQI varicose vein registry in 2019, Dr. Asher's group published the safety and efficacy of endovenous ablation in octogenarians, nonagenarians, and centenarians, and concluded that venous ablation is safe and effective across all age groups, and age alone should not be used to deny patient venous ablations. In 2019, Dr. Lam from Taiwan published endovascular ablation therapies for varicose veins in elderly patients and concluded both endovenous laser and radiofrequency ablation are feasible, safe, and well tolerated by elderly patients. Lastly, Dr. Keogh published a multi-center 829 patient study that concluded EVLA performed as an outpatient procedure seems to be effective and safe in the elderly population as compared to the younger age group. Ladies and gentlemen, in conclusion, vascular specialists are performing varicose vein procedures in elderly patients. When performing procedures, we are likely to perform truncal procedures alone. Elderly patients benefit from varicose vein procedures with statistically significant improvement in the venous clinical severity score and patient-reported outcomes. Importantly, these patients have a low rate of leg and systemic complications. And finally, superficial endovenous disease therapies are safe to perform in the elderly.
Thank you, Leon. Great presentation as usual. Before we go to questions from the attendees, let's listen to the comment from Willie. Please play the video from Willie.
I am honored to make comments on Dr. Kamnek's talk on superficial venous intervention in the elderly. Over the last 7 minutes, you have heard Dr. Kamnek's detailed description of a number of recently published trials using the US VQI VVR dataset, indicating that superficial venous intervention, it is not only safe, but effective in the elderly population, and that is defined as greater than the age of 80. More than so, you could see that a similar result is also being published from the European colleagues as well as the Taiwanese colleagues. My comments are as follows. Number one is superficial venous intervention appear to be safe and effective in elderly population using standard measuring metrics such as the VCSS and the patient-reported outcome measures. Number two, that those patients who underwent truncal ablation only versus those with truncal and adjunctive procedure at the same time seem to benefit the same. Now, in the elderly population, that we do see that the trend is to do less adjunctive procedure at the same time and simply do the truncal ablation. And number three is that age is no longer a barrier to superficial venous intervention in the elderly population. And I want to thank you all for your attention.
Thank you, Ali. This is a very nice comment. I have two questions from the attendees. One of them, of our guys, is asking, is varicose veins in elderly age-related? Does, in other words, he's asking, does the age increase the incidence of varicosity?
In my opinion, yes. And in the literature that supports it, yes. I would like to know if anybody disagrees with that.
Another question is asking that varicose vein in elderly is a long-standing varicosity. Does it mean we need different modality for treating such a long-standing varicose veins?
That's an interesting, really dynamic question. And the reason that I say it's dynamic, in the research that I performed, it showed that the elderly had a higher recanalization rate. And that may be something that alludes to the fact that the vein walls may have changed over time. But I have no literature really to support it. other than thought, but maybe somebody knows of literature that would support it. But it makes sense to me that that would be one explanation as to the recanalization rate.
Okay, thank you. Thank you. It is a very good answer, very good suggestion. And I think we have to think about it and let's make some work about treating varicose vein in both elderly and in children. I think it worth further studies.
Could be interesting to look at the pathology of the vein prior to ablation, as well, you know, in the octogenarian group and the younger group, and see if there are actually differences in the varicose veins. It may have to go down to a nano level as well, but it's an interesting thought.
Thank you, Lowell. Thank you very much. Now I would like to leave the mic to Professor Ahmed Din Hussein to make some final comment and give the way to face fake news about varicose veins. The mic is yours, Ahmed.
Yes. Thank you very much, Professor Fakhri Ayman, for assembling such a stellar of the giants in the field. All the lectures were really masterly. And I'll highlight first the importance of such webinar. It helps us actually, the importance of such a webinar is double-fold. First, it helps us to realize that in our practice, for phlebology patients, we are not flawless. Second is quite a support to face countless questions that I both keep getting questions from my patients, and they rely on the fake news frequently. So how to face that? Let me grab the lead from Professor Omar Al-Farouk, our dear friend, right away. And it's good to have fact-checking machines. It's good to have the technology. What about the illiteracy in our country, especially in Upper Egypt? People are not using this sort of technology, and they hardly approach the specialists in the first place. So they go shopping around, and you know probably better than me that this is the way how things go back home. So once again, if I would like to wrap up this very interesting webinar, I'll throw just a few highlights. Sergio first talking about varicose veins in athletes. Now, I do believe that as important as all the details he mentioned, but remains one question. It's not valid only for the varicose veins in athletes, but it's valid for the different scenarios we have witnessed tonight all together. Which group of muscles take over the burden, and in which sports to be studied? So that remains, because as elegant and as informative as it was tonight, but it leaves us, like any very high quality webinar, it leaves us with so many questions as well. So it's not only about a dedicated sports team, and you, Ayman, one of our great athletes, I know that, and not only the sports medicine dedicated team, but for each sport, probably we should have a different protocol, depending on the group of muscles that are taking over the burden to be studied, looking for the escape points. Question number 2, which sports needs pharmacoprophylaxis? I don't have an answer to that. You might have, or Sergio has, probably. Now, shifting to Samer. You know, Samer, this might be of interest to you. Last year, 5 consecutive cases which I had to deal with, ladies in between pregnancies. 4 out of those 5 were having pelvic venous disease for one or other reason, and in 4 cases I had to stent them for the iliac vein with or without embolization for the gonadal veins. However, the first question that would come to me, well, when could I be pregnant for the following pregnancy? Samer highlighted something very, very important, which is close collaboration with the obstetrician. This is mandatory. I think I told her, well, I have to cover you for the coming 3 months with antiplatelets / anticoagulation for some time with the stent in, but when would you be pregnant? It's not me to answer. So when the lady consulted her obstetrician, he told her, well, not before 6 months. And once you take this decision, I will give you low molecular weight heparin for the whole pregnancy period. So again, lesson time and again. After Samer, I think it was Tanya. Oh, no, I think it was Victor Canada. Children, again, is a very hard front, whether dealing with hemangioma or arteriovenous malformations, and the parents come and getting their sources from fake news in social media. Probably some of them can browse the net here and there, but they fall again a victim to the fake news. And then they are so concerned, and they don't know the difference between hemangioma and in the arteriovenous malformation and the different natural history of either. So once they are reassured, if they are lucky, we can help them, but there's still a long way to go. Now, Tanya mentioned that the basic thing, which I respect very much, there is no such thing as topical treatment of varicose veins. That's the reality, because of different factors out there. So we should explain that to the population. The beautiful document released in Dubai 2 years ago was great, but we still have lots of homework to do. Finally, Lowell was much informative about the venous diseases and varicose veins in the elderly, and I couldn't agree more with what he said about age is no contraindication or no reason to deny the patient the opportunity to get his varicose veins treated. So once again, I enjoyed to the maximum this evening, and thank you again, Ayman, for this huge effort. I do hope we can build upon that with probably another document similar to the one that was released in Dubai, but this time I promise there will be an Arabic translation, and I will take care of that. I know I'm late for that, so Sergio, forgive me for this. Thank you, Ayman, and thank you all.
Thank you, Ahmed. Thank you all friends for joining us today. Thank you, Sergio, for developing the idea of fake news. It was a great point to raise in our community. Thank you for VWIN. Thank you for IUP. Thank you for all our speakers today. You were great. Thank you for our organizing committee, PL events. Thank you for organizing this nice evening. Before I go, I would like to invite you for very nice events. Please join us in Egypt from May 1st to 3rd, and joining our 11th International Congress of Egyptian Venous Forum. And please be ready to use the magic carpet with Aladdin, who is going to help his lovely girl Yasmina to treat her varicosity. Let us see for the next time how Aladdin will help Yasmina to cure her varicosity. See you on the magic carpet and see you all. Have a nice evening. Bye-bye.
Thank you.
Hey,
Bye.
bye.
Thank you. Bye.
Bye. Thank you, Ayman.
Thank you.